You have been given a case of a student presented with headache and rash. Regarding differential diagnosis, make a quick list of possible causes of a given presenting complaint, and ask questions to rule in or out the possible differentials, as in this case: bacterial meningitis, subarachnoid hemorrhage, migraine, are the top differentials in our list. For headache, it is better to ask about pain questions using Socrates PDA site. Where exactly do you feel the pain most? Is it one side of your head or both sides? Is it more around the eyes or on back of your head? Onset: how did the pain start? Character: could you please describe the pain for me? Radiation: does this pain go anywhere else? If answer is yes, then ask where it goes. Pain which radiates into the neck and shoulders may represent meningism. Associated symptom: stick on your diagnosis. Timing: does it from specific timing? Has it happened before? Is the pain constant, or does it come and goes? Exacerbating factors: does anything make it worse? Relieving factors: does anything make it better? Scale: if I was to give you the scale from 1 to 10, 1 is lowest and 10 is highest, how do you scale the pain? Progression: is it the same as it started, or getting worse? Duration: how long it is present? Anything else? Associated symptoms: ask, do you see double? Have you noticed any problem with your vision? Do you have trouble in seeing the sides? Ask about any positive symptoms like fortification, scintillations, floaters, and spectra like flashing lights and zigzag patterns are associated with migraine. Retinal detachment, occipital lobe lesions. Ask, does the light hurt you? Do you have neurological sign? Any body weakness? Any numbness? Any tingling? Any balance problem? Any difficulty in coordination or any jerky movements of limbs? Any vomiting, spinning sensations around or tinnitus? Let's analyze the questions to make a possible diagnosis and rule out possible conditions that can cause headache. Let's begin with acute single episode of headache. For meningitis, ask about fever, photophobia, stiff neck, body rashes, coma. For encephalitis, question about odd behavior, seizures or decreased consciousness. For subarachnoid hemorrhage, check for sudden headache with or without stiff neck. For sinusitis, find for tenderness of face, coryza, postnasal drip. For head injury, ask for any injury, cuts or bruises, altered consciousness, lucid interval, amnesia. Eye problems, ask about pain, redness, watering, discharge, blurriness or decreased vision. Next is acute recurrent attacks. Check for migraine by asking any pre-attack aura, visual aura, vomiting, sensitivity to light, noise, or movement. Does noise bother you? Does light bother you? Check for specific triggers like consumption of any specific food or drinks like alcohol, cheese, any lack of sleep, fasting, extensive exercise or stress. For cluster headache, typically nightly pain in one eye, for 8 weeks, with watering of eyes and nose. Glaucoma can be picked by asking red eye, sees halos, fixed big oval pupil, decreased visual acuity. Trigeminal neuralgia, check for distribution of intense pain along nerve root, lasting for a few seconds and triggered by opening jaw, chewing, talking or shave. Further, for subacute onset headache, ask for giant cell arteritis by tender scalp, age more than 50 years old, vision changes. Next is chronic headache defined by pain for more than 15 days per month for longer than 3 months. It includes tension headache, typically described by a type and around my head, with history of stress at work home. Further, check for chronically elevated intracranial pressure by asking, is the headache worsens on waking, associated with focal neurological signs. Chronic daily headache has a long history of analgesic overuse over 1 or more year. Cervical spondylosis, ask about neck pain associated with headache. Moreover, 4. Abscess. Ask for fever and pattern of progression. Next, tumor. Check for weight loss, night sweats, and worsening of headache by bending forward. Additionally, ask about any vision problem, especially on looking to sides, to check for bitemporal hemianopia, as in pituitary macroadenoma, MEN1, and non-functioning adenoma. For associated glands problems, ask about any change in facial appearance or any change in size of hands or shoes, as in acromegaly. Regarding Cushing disease, ask about any bruising of skin, any weight gain, any abnormal bone fractures, and fatigue. Meanwhile, regarding depression, ask the questions related to mood, any recent change in sleep, loss of interest in activities you used to enjoy before, any guilt about any particular thing, any change in the level of energy towards your daily life activities. What about your concentration? Are you easily distracted, or have poor focus? How is your appetite? Are you enjoying your meals? Have you ever think that life is of no more worth, or any thoughts to harm yourself or others? Next is postherpetic neuralgia. Ask about rash and typical distribution of corresponding nerve. 4. Caffeine withdrawal. Ask about habits of coffee consumption or any recent change in the quantity to be used. Ask about use of medication, especially for painkillers, and duration and quantity to be used. At this point, we have ruled out possible differentials and make our approach aligned towards a possible diagnosis of bacterial meningitis, due to neck stiffness, headache and photophobia, nausea and vomiting, focal neurological deficit, constitutional symptoms of infection, rash. To support it, we can perform a quick physical examination and lab investigations. As in this case, we can check signs for meningism, neck stiffness, photophobia on fundoscopy, Kernig's sign, fever, look for a rash, meningococcal meningitis, petechial or purpura rash indicates associated septicemia, brief neurological examination, cerebral abscess, localizing signs, upper limb, pronator drift, lower limb, extensor plantar, cranial nerve palsy, cerebral edema or increasing intracranial pressure, reduced Glasgow coma score, unilateral dilated pupil, third nerve palsy, and papilledema, hemodynamic stability, septic shock, pulse and BP. Now it's the time to tell the patient about the management part, including investigations and treatment. Regarding investigations, we have options of blood culture, lumbar puncture, send CSF sample for lab examination, differentiate bloody tap from subarachnoid hemorrhage by assessing xanthochromia, bilirubin from degraded RBCs turn CSF yellow. Regarding treatment, do not delay antibiotics, penicillin, high dose, intravenous, immediately if diagnosis is suspected. Meningitis is a notifiable disease. Treat close contacts. Meanwhile, address the concerns of the patient. In the end, it's the time to close the case and talk to the examiner.